On March 11, 2020, the World Health Organization declared COVID-19 a pandemic. By then, the virus had already reached 114 countries, infected 118,000 people, and killed over 4,000, with cases outside China surging 13-fold in just 2 weeks. 5 biological features made this virus nearly impossible to detect and contain. 3 interventions finally worked. We are counting them down, starting with the trait that gave the virus its earliest head start. In the 5th place, the virus established a hidden delay within the human body. A March 2020 analysis of 181 confirmed cases in the Annals of Internal Medicine estimated a median incubation period of 5.1 days, with 97.5% of symptomatic patients taking up to 11.5 days to show any signs of illness. This meant an individual exposed on a Monday could reach peak viral shedding by Thursday while still feeling entirely healthy, continuing their normal work and social routines well into the following week. At the same time, early surveillance data from China in February 2020 classified roughly 81% of laboratory-confirmed cases as mild or moderate. Because these initial infections mirrored the common cold or seasonal flu, individuals dismissed their early symptoms entirely. This combination of a slow physical onset and mild early illness allowed the pathogen to circulate silently within communities for days before public health systems even flagged a potential infection. This biological buffer systematically bypassed early symptom-based screening, giving the virus an invisible head start before traditional containment measures could react. In the 4th place, an early focus on contaminated surfaces redirected global prevention efforts toward the wrong threat. On March 17, 2020, a study in the New England Journal of Medicine reported that viable virus could survive on plastic and stainless steel for up to 72 hours and on cardboard for 24 hours. The same laboratory paper documented that the pathogen remained viable in aerosols for the entire 3-hour duration of their testing. Yet, public attention focused almost exclusively on the surface data. This 72-hour headline prompted massive, expensive disinfection campaigns, with transit authorities shutting down train networks for daily deep cleaning, and offices sanitizing every physical package. While communities spent billions of dollars on this intensive hygiene theater, the true vector of spread went unaddressed. Later evidence revealed that surface transmission represents a low risk compared to direct inhalation of airborne particles. By treating the pandemic as a threat of dirty surfaces rather than shared AIR, global containment systems misallocated precious resources during a critical window, leaving populations exposed to the invisible, lingering plumes where the real infection risk persisted. In the 3rd place, the virus exploited a mathematical vulnerability in global defense networks. It did not spread in steady, predictable lines. In March 2020, researchers at the London School of Hygiene and Tropical Medicine estimated the virus's dispersion parameter known as K at approximately 0.1. This statistical value revealed extreme overdispersion, indicating that roughly 80% of secondary infections were generated by just 10% of carriers. Empirical proof of this skewed dynamic emerged from a massive contact tracing dataset in Karnataka, India, which monitored 956 index cases and their contacts. The data confirmed that a mere 8.7% of infected individuals caused 80% of all onward transmission. These explosive bursts occurred almost exclusively in crowded, poorly ventilated indoor settings, such as meat processing plants, care homes, and choir rehearsals, where sustained vocalization built up high concentrations of infectious particles. Traditional public health infrastructure was built for linear pathogens like influenza, where tracing forward from one patient to the next makes logical sense. Against SARS-CoV-2, this workflow was structurally obsolete. Tracers spent weeks pursuing contacts who would never pass the virus on, while massive, undetected clusters erupted simultaneously in shared indoor spaces. This mathematical asymmetry meant containment systems were perpetually chasing dead ends, leaving the true engines of the pandemic completely unmonitored. In 2nd place, global containment networks suffered a systemic failure by ignoring how the pathogen actually traveled through the AIR, leading to a dangerous misalignment between official health guidelines and real-world transmission. On March 10, 2020, 61 members of the Skagit Valley Chorale met for a routine rehearsal in Mount Vernon, Washington. Throughout the 2.5-hour indoor session, the participants strictly avoided physical contact and frequently utilized hand sanitizer. Despite these precautions, this single gathering resulted in 53 infections and 2 subsequent deaths, producing an astonishing attack rate of 86.8%. The explosive, near-universal spread among individuals who remained physically distanced was clear evidence of aerosol inhalation, where microscopic particles remained suspended in stagnant indoor air. Yet, institutional guidance lagged far behind the physical reality. On March 28, 2020, the World Health Organization published prominent public guidance explicitly asserting that the virus was not airborne, claiming instead that transmission only occurred through heavy droplets that fell rapidly to the ground within a few feet. This messaging ignored decades of industrial and aerosol physics. By July 2020, the scientific community revolted, with 239 scientists publishing an open letter in the journal Clinical Infectious Diseases, presenting undeniable evidence that fine respiratory particles were driving indoor outbreaks. Though international bodies eventually offered a partial, highly qualified acknowledgement, the policy damage was done. For over a year, municipal guidelines prioritized costly surface disinfection over mandatory masking and indoor ventilation upgrades, leaving the public unprotected against the dominant route of exposure while focusing their efforts on the wrong threat. And in first place, the ultimate vulnerability that completely undermined global containment systems was the silent spread of the virus from individuals who showed no outward signs of illness. In the early months of 2020, public health authorities realized that waiting for symptoms to appear was already too late. A CDC analysis of 157 locally acquired cases in Singapore identified 7 distinct transmission clusters where the virus was passed on 1 to 3 days before the source case felt sick. This was not an isolated phenomenon. A German outbreak cohort study calculated that approximately 75% of all transmission occurred while carriers were still in this pre-symptomatic window, feeling healthy and moving freely through their communities. Further proof of this hidden force came from the quarantined Diamond Princess cruise ship, where systematic testing revealed that 331 of the 712 positive cases, nearly 47%, were completely asymptomatic at the time they tested positive. This biological reality exposed a fundamental mismatch in global defense strategies. For decades, public health systems relied on symptom-based detection, border temperature checks, thermal cameras, and self-reporting. Because these protocols were calibrated to visible illness, they systematically missed the very individuals driving the exponential expansion of the virus. The realization of this silent transmission forced a structural shift in how the pandemic was fought. Containment could no longer wait for symptoms to manifest. Instead, interventions had to target the physical mechanisms of transmission itself. Universal masking was introduced to intercept viral emission at the source, catching infectious aerosols before they could enter shared spaces. Ventilation retrofits focused on diluting and removing lingering indoor air currents, preventing the accumulation of unseen pathogens. Concomitantly, mRNA vaccines worked by directly reducing human susceptibility and preventing severe outcomes. By shifting the defense from passive symptom screening to active environmental and biological barriers, public health systems at last matched the real-world behavior of the virus. Across these 5 mechanisms, one truth emerges. Our defenses failed because they fought the wrong war. Traditional containment targeted symptoms, while the virus spread silently through the air. We only turned the tide when interventions matched actual biology, a critical lesson we must apply before the next outbreak arrives.